Today I'm here to talk about genetics of cardiovascular malformation. Now, if you take cardiac lesions which have genetic predisposition, it could be structural heart defect, it could be valvular heart lesions, aneurysms, cardiomyopathy, heterotaxis, and arrhythmias, as well as late onset cardiovascular diseases like coronary artery disease, hypertension, dyslipidemia, heart failure, and myocardial infarction as well have genetic predisposition. So in this talk, I will be mainly focusing on genetics of structural heart defects and bit of valvular heart lesions and aneurysms. So if you take incidence of congenital heart disease, it ranges from 4 to 8 per thousand live births. It accounts for 1/3 of all major congenital anomalies. Out of these 4 to 8, 2 to 3 are severe heart defects like conotruncal heart defects, single ventricles, hypoplastic left heart, etc. So if you take tiny trivial lesions, bicuspid aortic valve, the incidence further increases to almost 1%, and incidence further increases if you include prenatally diagnosed spontaneous abortion, stillbirths with congenital heart disease. So with a whole lot of new knowledge about developmental aspect of the heart, embryology, it's very complex. There are many pathways, transcription factors, epigenetic factors, and the target genes, around 400 genes, which are involved in the development of heart. And genotype-phenotype correlation is not very simple because now we know that same gene mutation can cause isolated CHD as well as syndromic CHD. And also some of the genes are known to have late effects. Initially, it might present as a structural heart defect. And the later part of the life, the child can have, in adulthood, can have dilated cardiomyopathy. So essentially, genotype-phenotype correlation is not very simple. And there are many other signaling pathways which are being described. The genes in these pathways are known to cause congenital heart disease. Yeah. That is nodal notch signaling pathways, SHH signaling pathways, RAS-MAPK pathways that causes RASopathies, and the newer research says a lot of chromatin genes that is involved in the epigenetics. So there is always a presence of additional genetic variants or a modifier genes in these disorders, as it applies to other disorders like neurology, hematology. The severity, post-operative outcomes, operative course, transplant-free survival will differ based on the additional genetic and non-genetic factors. So when you have a child with congenital heart disease, why you want to know the genetic etiology? Why clinical genetic evaluation is important? The first thing is parents wish to know why their tiny little baby, a 1 month old or a newborn child, have this heart disease, which is sometimes life-threatening, and how the treatment should be, whether it is medical, surgical, what are the long-term implications, number of surgeries, all those things. And the most important thing is there might be additional organ involvement, that is extra cardiac manifestations, which may or may not be evident at birth, right? It might be an age-dependent phenomena. So sometimes when the child, especially the infant, presents with congenital heart disease, it might be in a window to early diagnose the syndromes, especially, as I said, in infants. And why we should know the genetic etiology, the other important thing is the treatment prognosis will differ. Clinical management, that is medical, surgical management strategies, outcome differs based on whether it is syndrome or isolated congenital heart disease. Further, prognosis of isolated congenital heart disease depends upon the severity of the lesions, whether it is hypoplastic left heart syndrome or a conotruncal heart disease, or whether it is a simple septal defect. So once we know the underlying genetic cause, the genetic counseling will become accurate, and there would be a risk of recurrence, reproductive options, and implication to other family members as well. So, as any other birth defects, the congenital heart disease etiologically is highly heterogeneous. It could be chromosomal, single gene, epigenetic alterations, somatic mutations, and newer recent research says some microRNAs, placental methylations, the other causes being teratogen. But the most important still now, the cause in majority of the cases considered is gene-gene or gene-environmental interactions causing the congenital heart disease. So when you have a child with congenital heart disease, when you see, it's very important to classify them, whether it is syndromic or non-syndromic. It not only helps us in prognosticating, counseling, but also it helps in which test we should go for, whether chromosomal, single gene, based on whether it is syndromic and non-syndromic. So as I said, in majority of the cases, the cause remains unknown in as many as 50% of the cases. So, but evidence with the, the developmental genes, the evidence suggests that 90% of all the CST have some sort of genetic contribution. So now the explanation being oligogenic, or it could be a polygenic, or it could be an gene environmental interactions. And most of these unknown causes are isolated congenital heart disease. In a large cohorts of unknown etiology, the diagnostic yield was very low. 8 to 18% were found to be of single gene origin, and most of them were epigenetic genes. So with the new experimental studies, hopefully we will be able to identify the newer genes. So what the recent research says about genetics of congenital heart disease of unknown etiology. There are a lot of enrichment of de novo protein truncating variants in the syndromic CHDs, which are not inherited, whereas significant enrichment of inherited protein truncating variants from the unaffected parent in the isolated congenital heart disease, suggestive of incomplete penetrance. And de novo damaging variants were more strongly associated with the adverse outcome in terms of post-operative course and transplant-free survival. The other highlights in the recent research is, the group of lesions like left-sided lesions, right-sided lesions, mild lesions have different genes and different pathways involved. And CHD with neurodevelopmental outcome increases the diagnostic yield by 8 to 20%. And recent research says most of these genes are chromatin modifying genes. And always there is a presence of additional variant as a modifier, be it a single gene or a copy number variants. And also recent research says that adults with CHD are at higher risk of cancer compared to the general population. So there are again different loci, different mechanisms in like mosaic variants, whole genome sequencing in unknown cases. There are some genes which are being mentioned like microRNAs, non-coding regions, promoter, regulator sequences, mitochondrial sequences, along with rare structural variants in like TBX5 and FLT4 genes. So this is about recent research in the unknown cases which has happened in the recent years. So coming to isolated congenital heart disease and its genetics, majority of them are isolated, 70%, and the commonest cause for these is still considered multifactorial, that is gene-gene, oligogenic inheritance, or in some cases it could be single gene or underlying copy number variants. And around 2% could be accounted due to environmental and teratogenic causes. So recent research says that around 3 to 10% of isolated congenital heart disease are single gene origin, mostly autosomal dominant de novo variants. In a study done by Zaidi et al., who studied severe sporadic CHDs without family history, 10% were due to single gene cause. Most of them were histone modifying genes, that is chromatin modifying genes. When we take the positive family history, the diagnostic yield in single gene disorder increases to 31%. And in isolated CHD and copy number variants, 3 to 5% are due to copy number variants. If you take selected group of cardiac lesions like conotruncal heart disease, there the copy number variance slightly increases to 5 to 10%. So now we know that increasingly single gene origin rare CNVs account for isolated congenital heart disease, but one has to remember that same genes can cause both isolated as well as syndromic congenital heart disease. Like PTPN1 gene can cause isolated pulmonary stenosis as well as Noonan syndrome. Similarly, TBX5 can cause Holt-Oram syndrome, can cause septal defects as well. So there is a lot of overlapping genetics between syndromic and single genes, which causes isolated congenital heart disease, challenging the genotype-phenotype correlations. So currently, we don't offer any single gene testing in a clinical practice for isolated congenital heart disease because the diagnostic yield is very low. But however, there are some suggestions like severe congenital heart disease with family history should be offered genetic testing. However, one should counsel the parents about the low diagnostic yield along with rarely clinically useful. So that has to be mentioned to the parents who want to undergo genetic testing for isolated congenital heart disease. So these are the different genes which have been reported, published in isolated congenital heart disease, starting from septal defects to bicuspid aortic valve to hypoplastic left heart syndrome. These are the various genes. So the management of isolated congenital heart disease in a genetic perspective is, whenever you see an isolated cardiac lesions, the management and medical and surgical management will happen at the cardiologist and cardiac surgeon. One should understand the late complication of CHD based on the genes if the reports are available. If not, based on the family history, pedigree analysis, if it fits into Mendelian pattern, you can counsel the parents accordingly and suggest extended family screening and provide them risk of recurrence. If it is a sporadic CHD with no genetic testing done, especially for the risk of recurrence, one can offer empiric risk of recurrences based on the type of cardiac lesion, which ranges from 1 to 3%, highest for transposition of great vessels in some studies, up to 5 to 6%. So you can offer these empiric risk of recurrence figures to the parents. So if one of the parent is affected, the risk figures, if the mother is affected, risk to the offspring is higher compared to the father is affected. So if mother is affected, it ranges from 2 to 20%. So 2 to 5% is for TOF. Aortic stenosis, it is as high as 20%. If the father is affected, risk to offspring is less, ranging from 1 to 5%. This is overall figure, population incidence 0.5%. Sibling of an isolated case, overall it is 2 to 3%. Half sib and second degree relative 1 to 2%. If father is affected, risk to the offspring is 2 to 3% on an average. Mother 5 to 6%. If there are 2 affected siblings, risk of recurrence increases to 10%. If there are more than 2 affected first degree relative, then it increases to 50%, suggestive of autosomal dominant disorder. So these are the young children who were operated at our hospital. Like this boy was operated at the age of 21 days for TGA and septal defect, VSD and ASD. Now he had come to us with some poor scholastic performance at the age of 18 years, with subtle dysmorphic features not fitting into any classical syndrome. We offered them chromosomal microarray which didn't show copy number variants, karyotype normal. So we don't know the cause. Hopefully, whole exome might give some answer, might not give some answer at all. The other girl was operated for TOF. There was a family history also. She wanted to get married and have children. She wanted to understand risks to her offspring. So how do you counsel this lady for, planning the babies? So one is we offered in, because this was way back in 2000, I think 8 or 9. That time microarray was not easily available. Cost was high. We offered a chromosome and FISH for 22q to rule out underlying DiGeorge syndrome, which was negative. So based on the cardiac lesion, we offered our empiric risk of risk to the offspring ranging from 2 to 5%. And also at the same time, we should tell them concordance of the same type of CHD is 37%. Means if it is TOF, need not the child will have TOF. It might have just ASD or VSD. So concordance is around 30 to 40%. So that has to be mentioned. So what is the pre-pregnancy counseling in all cases of isolated family with isolated congenital heart disease? One is periconceptional folic acid supplementation. Ensure rubella vaccination is complete before pregnancy. Optimal management of known risk factors if they are there, like diabetes, epilepsy, or any sort of chronic illness. Avoid drugs before and during pregnancy. If unavoidable, use it with consulting medical professional. Stop smoking and no alcohol. Avoid exposure to these heavy metals and promote healthy habits, healthy weight, nutrition, early prenatal care, and physical activity. Followed by a good malformation scan by fetal medicine specialist, including NT, and along with ultrasound, fetal echo at around 18 to 20 weeks, and follow-up echo if necessary at 20 to 24 weeks. So that was about isolated congenital heart disease, genetics and its management in genetic clinic. Coming to syndromic CHDs, it could be a chromosomal cause, single gene disorder, or it could be a teratogenic cause. Unlike other birth defects, these CHD management slightly differs because they could, along with syndromic outcome, the cardiac lesion might require more number of surgeries, like 3 surgeries, not only at young age, even in the adult age. And the cost of the surgery, duration of the stay in hospital, quality of life, all these things need to consider while counseling these children with congenital heart disease. So to begin with chromosomal causes, it could be as any other birth defect, it could be numerical or structural. So numerical could be trisomy, monosomy. Structural could be balanced, unbalanced chromosomal structural rearrangements. In the pre-molecular cytogenetic period, before the advent of FISH and microarray, 5 to 12% of the newborns with CHD were chromosomal causes, the commonest being Down syndrome. If you take fetuses, the chromosomal causes increases to 20 to 30%. Followed by when the FISH was introduced for DiGeorge syndrome, because this particular deletion accounted for 1 to 5% of all live borns with CHD. And then microarray, when it was introduced, then in addition to these, 10% and 5%, up to 14%, 4% in isolated congenital heart disease, 15% in syndromic CHDs were due to underlying microdeletions and microduplication. In selected group of syndromic CHDs, the CNVs can go up to 30% of the cases. And the clinical presentation of these chromosomal syndromic CHDs is They present with extracardiac manifestation, facial dysmorphism, minor malformations, growth retardation, with or without intellectual disability, or they can just have learning difficulties. So common aneuploidies which present with congenital heart disease, as you all know, is Down syndrome, trisomy. This is trisomy 13 and trisomy 18. You can see the triangular face, IUGR baby with overlapping fingers, clenched hands. So in Down syndrome, the commonest cardiac lesion is AV canal defect, right? Wherever consanguinity is prevalent, there septal defects are common. So 50% will have congenital heart disease. Now, good medical and surgical care, the lifespan of these children with congenital heart disease have improved. Sometimes adults are at risk of having valvular heart lesion. If found symptomatic, they need to be screened. Trisomy 18 and 13, majority of them have congenital heart disease. Prognosis is poor. Generally, surgery is discouraged. Most of them die by 1 year of age, even if you do any medical surgical therapies. Even if they survive, it is associated with severe physical and mental handicap. So this is an unusual case of mosaic trisomy 9 survival in a child with syndromic CHD who presented with complex congenital heart disease, facial dysmorphism, and if you can see here, mosaic pigmentary skin lesions, right? So when we did the blood karyotype, 4 cells showed trisomy 9, whereas 96 cells showed normal chromosomal complements. So this is trisomy 9. So we did the skin lesion PCR to look for whether it is trisomy 9 or normal. So in hyperpigmented skin, it was trisomy 9. Extra allele was coming from the maternal origin, and normal skin looking showed maternal UPD, suggestive of loss of paternal allele, right? So most of the cases are associated with severe psychomotor retardation and have multiple congenital anomalies, including congenital heart disease. The very rare cases of mild developmental delay have been reported. Maternal UPD9 is reported even in a healthy phenotype. In these cases of mosaics, the risk of recurrence is almost nil. So next commonest chromosomal cause with chromosomal cause of syndromic CHD is Turner syndrome. This is a child typical, sometimes they have a typical face. The most important finding is downturned corners of the mouth. So that is the important thing. In infancy and early childhood, it's difficult to diagnose child with Turner syndrome. Some of the clinical manifestations in newborns could be web neck, short neck, puffy hands and feet. Otherwise, they can present you with short stature. Most of the time, the diagnosis is delayed. They usually get diagnosed with primary amenorrhea, poor secondary sexual characters, and physical abnormalities. Like here, you can see the web neck. So this is the karyotype showing 45X. And these are the other chromosomal abnormalities which are seen in Turner syndrome, the commonest being 45X. Now, congenital heart disease, left-sided cardiac lesions are common, can be seen in as many as 25 to 50% of the cases. The commonest cardiac lesion being coaptation of aorta and bicuspid aortic valve. Even if the initial cardiac evaluation is normal, the child have to be screened every 5 to 10 years for aortic root dilatation at transition, before pregnancy, and throughout the pregnancy. And the risk of mortality due to aortic dissection or rupture during pregnancy is around 2%. Further can be aggravated by associated comorbidities and pregnancy-induced hypertension. See, these are the congenital heart abnormalities. They are also at risk of having acquired heart disease because of hypertension, dyslipidemias, pregnancy, etc. So that needs to be kept in mind. So they need to be screened annually for lipids in addition to the heart. So this is another child who presented with multiple congenital malformation, facial dysmorphism. Mother gave an history of 6 recurrent spontaneous abortion. Child also had congenital heart disease, ASD, and severe pulmonary stenosis. So when we did the karyotype of the baby, it showed extra material attached to the chromosome 18, and mother was a carrier for 418 translocation. This balanced phenotype leading to unbalanced, that is partial trisomy 4q and monosomy for 18q. So these couples can be offered pre-implantation genetic diagnosis and screening. This is another family who presented with this sort of family history. She had 2 recurrent abortion. This child died of syndromic CHD. And again, this child presented with syndromic CHD. This time here, this baby was investigated, karyotype was normal. When we saw this child had CHD, dilated ventricles, facial dysmorphism, laryngomalacia, neuroimaging along with dilated ventricles showed posterior fossa crowding, and also there was rectal prolapse, and there were multiple minor malformations as well. Karyotype again outside was reported as normal. So what would be the next investigation here? Right? So the first and foremost important thing is look for the karyotype quality. Most of the labs don't maintain the proper quality. It was just to repeat the karyotype with so much obvious dysmorphic and multiple malformed baby. They had missed the extra chromosome material attached to this particular chromosome. Right? Just repeat karyotype if you think that it is very dysmorphic baby, multiple malformation, previous child, abortions. Best is to repeat karyotype. That would be a flow cost. So there was an extra chromosome material attached. When we did the parental karyotype, she was a carrier between translocation, balanced translocation carrier between 1 and 2. So that explained everything in this baby. So coming to the microdeletions and microduplications, these are the small deletions and duplication, small enough to be seen under microscope, usually in the size of less than 2 to 4 MB size. And these microdeletions and microduplications, which are not picked up by routine karyotype, they can be picked up by FISH, which is a targeted test, MLPA, which is again a targeted test. Microarray is genome-wide identification of copy number variants, whether it is microdeletion or microduplication. Again, clinically, they can present as multi-system involvement, or it can be just an isolated congenital heart disease. So these are the children with congenital heart disease, conotruncal heart defects. This child, puffy eyes, square nasal root, bulbous nose, small mouth, slender fingers. You can see tiny polydactyly here, cleft palate, cup ears. So what is the diagnosis? Conotruncal heart defects, Dye-George syndromes. Earlier known by different names, now we call them Dye-George velocardiofacial syndromes. So what is the underlying cause of here? 22q microdeletions, right? So which can be picked up by various tests, FISH, MLPA, and microarray. The use of microarray is like atypical deletions can be picked up. These are the atypical deletion, distal deletion, which can be missed by FISH. So atypical deletions can be picked up. Size of the deletions will be much more well-defined in microarray. It can pick up microduplication as well. Sometimes there will be a overlapping phenotype, right? Sometimes 22q microdeletions can have similar phase of 10p deletion or 22q microdeletion as well. So those will be picked up in addition to 22q microdeletion in case if we do the microarray. And of course, genotype-phenotype correlation will be much better in microarrays. So majority of the size of the deletions are 3 MB, and the small deletion 1.5 MB are familial cases. In 8 to 10% of the cases, these DiGeorge velocardiofacial syndrome can come from one of the parent. As you can see here, this child was affected with congenital heart disease. Mother was absolutely normal with normal cardiac echo, and she was a carrier. Here also, mother had subtle facial dysmorphism, but her cardiac echo was normal, was a carrier for 22q microdeletions. So parental FISH or microarray, whichever is feasible, is indicated for all children who are diagnosed with 22q microdeletion, irrespective of clinical phenotype, because the clinical phenotype is highly variable. So the risk of recurrence in next pregnancy ranges from 0 to 50%, whether it is familial or non-familial case. Clinical variability, that is what they say. Yeah. Penetrance is not complete. For various reasons, maybe modifier genes, other allele contributing, whatever reasons. So DiGeorge velocardiofacial syndrome incidence is 1 in 5,000 live births. As I said, 5 to 10% are familial. 1 to 5% of all type of heart defects are due to 22q microdeletion. Majority of them have congenital heart disease, and the commonest cardiac lesion being conotruncal heart defects, and these are all conotruncal heart defects. There are other associated complication in these children, hypocalcemia, mostly in newborn period, but sorry, I didn't get you. Yeah, that can be taken into account, but I think more than that, right-sided aortic arc is more common. Yeah. It might be an additional finding. You can take as many as possible. See, sometimes I go by lips. Lips is a more easy way to diagnose DiGeorge. So as additional clinical findings with your own experience, if you feel this is contributing to the phenotype, you could consider testing in those cases. It's like that. Does not have, unless there is additional finding, even prenatally diagnosed, we isolated, nobody will test. Only additional finding, you test them. Yeah, I think better to discuss and tell them about the low diagnostic yield. That's what, if for that they are ready, then go ahead with the testing. Yeah. Once in a while you do get isolated RSA. That means the sonographer has this as additional finding. There has to be some additional finding. Always, if you look closely, there will be some additional finding. That is what the article says. Whenever the large cohort, when they study, when they say isolated means they are properly checked. But unfortunately, in India, the quality is not uniform everywhere. Right. So additional comorbidities, what we call hypocalcemia, which is very common in the neonatal period, but can happen anytime, especially during intercurrent illness or during surgeries. As far as IQ is concerned, average IQ is seen in as many as 13% of the cases. And you can see the severe MR is seen in only 1 to 8% of the cases. So majority of them have learning difficulties, right? And other complications are otolaryngeal abnormalities. They can have progressive loss of antibody functions followed by diminished immunoglobulin levels, which can make them prone for recurrent respiratory infections. Psychiatric disorders are very common. As an adult, they are 25 to 30% are at risk of developing schizophrenia or schizoaffective disorder. These are the other rare manifestations in DiGeorge: renal malformations, craniosynostosis, or arthritis, CTV, etc. So there are certain guidelines which has to be followed whenever the child undergoes surgeries. That is perioperative calcium monitoring and supplementation, irrespective of prior history of hypocalcemia. Irradiated blood products and CMV seronegative blood components in patients with very low T cells and in cases with complete Dejod syndrome. Majority of them have got partial Dejod syndrome. There are two immune phenotypes. The one is the partial Dejod, where they have mild to moderate, some sort of immune function abnormalities, maybe T cell count, etc. And only 0.5% will have complete Dejod syndrome, where the immune functional abnormalities are severe. So in these severe cases, live viral vaccines are contraindicated, whereas in most of the partial Dejod syndrome, you can easily give all these vaccines. But however, there are some subset of partial Dejod syndrome behave like a complete Dejod syndrome after giving live viral vaccines. Very few reports are there. That has to be kept in mind. If feasible, before giving live viral vaccines, you can do CBC and some immune function tests to make sure that the profile is all right. So as it is not vaccines, live viral vaccines are not contraindicated. And why these children behave like a complete Dejod syndrome? Because of some underlying CD cell subtypes which have been reported in one or two articles, and also certain immune profiles make them prone for recurrent infections and autoimmunity. So there is a question here: can we suspect 22q deletion in CBC? Can we suspect 22q microdeletion in just a CBC? How? Huh? But many can have lymphopenia. By doing mean platelet volume. Platelet volume will be less in these cases. So these are the two different children with different phenotype, right? This child at 8 years old, he was admitted in our hospital with history of recurrent seizures from the age of 1 year, and he was on anti-epileptic drugs since age 6 years, that is 2 years. So at age 8 years, he presented with recurrent seizures, focal seizures, and he had history of recurrent ear infections, developmental delay, and poor scholastic performance. He was studying in regular school, but had some learning difficulties. Investigation showed hypocalcemia and intracranial calcification. And this is the other child who presented at 2 years of age with CHD, craniosynostosis, scoliosis, and facial dysmorphism. Both the facial dysmorphic features are entirely different. Here it is very subtle, here it is very obvious, and karyotype was normal. So what is the cause for these? What do you think? Both are due to 22q microdeletions. Both are 22q microdeletion syndrome cases. You can see the presentation, how it differs. Sorry? No, that is for immune function test. All are 22q microdeletion of 3 MB size. These both were 3 MB size. Sorry. No, the presentation is highly variable. Some parents can be normal, right? So you can see we stopped the anticonvulsants, gave only calcium supplements, child is doing well. And here also the craniosynostosis was operated, heart was operated, and child is also doing well. Right? So this indicates the highly clinically variable phenotype. Accurate diagnosis will lead to more accurate management. Now coming to Williams syndrome, other important cause of syndromic CHD, that is the commonest cardiac lesion being, how much time have? Okay. The commonest cardiac lesion being supravalvular aortic stenosis, and most of them have intellectual disability, usually mild. They can be easily diagnosed with two things. One is the face, another is the behavior. The moment they come in the OPD, they come to your desk side, they can shake hand, they can catch pen, they do whatever they want. Very over-friendly behavior, and they are anxious. So that gives an important clue to diagnose Williams syndrome. Associated problems could be hypercalcemia, hypothyroidism, and renal malformations. So the deletion is 7q11.23. Most of them are sporadic, autosomal dominant inheritance. Rarely parental inheritance is known, usually from the mother. Parental testing, unlike DiGeorge, we will not do routinely here unless clinically indicated. So these are the facial phenotype of different ages ranging from 3 months to 15 years. You can see the typical face is seen in around 3 to 5 years of age, right? What is that? Small nose, thick, full lips, wide mouth, sagging cheeks, right? And some of them can have hypopigmented iris. You can see the lips here, thick, full lips. Additional findings can be redundant skin on the dorsum of the hand, small, wide-spaced teeth, long, narrow face, and in the older age group, adolescents, the shoulders can be drooping. You can see the drooping shoulders, easily diagnosable. So the commonest cardiac lesion is supravalvular aortic stenosis followed by peripheral pulmonary stenosis. So again, you can use FISH, MLPA, or microarray for diagnosing microdeletion. So these are the other rare syndromic CHD with copy number variants. This is 17p13.3 deletion, that is Miller-Dieker syndrome, with lesioncephaly and characteristic face with thin lips, upper lip, anteverted nares, and bitemporal narrowing. And this is 1p36 deletion, high forehead, high broad forehead with straight eyebrows, deep set down slant eyes. So this is another child who was admitted for bronchiolitis. Pediatrician called us because of macrocephaly. Macrocephaly led to neuroimaging, which showed dysgenesis and hypoplasia of corpus callosum and left cerebellum as well. So when we did, karyotype was normal. These were the typical dysmorphic features of this particular child. When we did the microarray, it showed 1.4 MB 7q duplication. The same region which causes deletion, the duplication of the same region is termed as 7q11.23 duplication syndrome. So this child is a 7q1123 duplication syndrome associated with reduced penetrant and variable clinical features. The commonest presentations are ID, autism, macrocephaly, characteristic facial features, and variable internal organ malformation, including congenital heart disease. Here, it was inherited from the father, who was a school dropout. His echo showed VSD, which was spontaneously closed by RCC prolapse. So use of chromosomal microarray in congenital heart disease increases the diagnostic yield like any other, scenario if you take intellectual disability, especially with multiple malformations with no obvious known syndrome. If standard chromosomes are normal, one should go for microarray. In fact, it is the first line of investigation in many centers across worldwide and India as well. And it increases the diagnostic yield and lead to accurate genetic counseling. So coming to single gene disorders, it could be Mendelian, non-Mendelian inheritance. 5 to 26% are due to single gene causes. The presentation can be syndromic as well as isolated congenital heart disease. So these are the common syndromes with congenital heart disease. Ellis-1-Crevald, they present with congenital heart disease. Along with that, they have short limbs, narrow thorax, polydactyly, dystrophic nails, characteristic skeletal X-ray findings. You can see absent alveolar sulcus, they have multiple frenulae as well. This is a child born to consanguineous parents. So underlying genes, there are two genes, EVC and EVC2 gene. Both are localized in the same region. 60% have congenital heart disease. The prognosis depends upon the complexity of the underlying malformation, that is cardiac. There are other rare genes which have been recently reported in the 2023 Journal of Medical Genetics, who are negative for these particular two genes, which account for majority of the cases, can be looked for additional these rare genes. And some of the heterozygote carriers can present with disproportionate short stature and polydactyly as well, which is called as Weier's acrofacial dysostosis. Coming to Noonan syndrome, again, it is the commonest cause of syndromic CHD. The incidence ranging from 1 in 1,000 to 1 in 2,500 live births. It's a dominant disorder. Again, highly variable clinical severity. They have a characteristic face, and the commonest cardiac lesion is pulmonary stenosis followed by hypertrophic cardiomyopathy. And these are the other associated findings, like they have a bleeding tendencies, hearing loss, hypothyroidism, and undescended testes, as well as short stature. Intelligence can range from normal to intellectual disability. Usually it is mild, which can happen in 15 to 35% of the cases. So there are many Noonan-like conditions like Costello, cardiofasciocutaneous syndrome, Noonan syndrome with neurofibromatosis, Noonan-like multiple giant cell lesion syndrome, capillary malformation, arteriovenous malformation. All these have overlapping phenotype with the Noonan syndrome cases, right? So now we know that they are collectively called as rasopathies, and they are due to this particular pathway gene variants, which leads to gain of function, leads to hyperactivation of this particular signaling pathway, leading to Noonan syndrome and other related disorders. So these are all children with Noonan syndrome, molecularly diagnosed with congenital heart disease. They have a typical face, starting from flat facial profile, low set posteriorly rotated here, curly hairs, hypertelorism, downslant eyes, right? We can see here ptosis, droopy eyelids. Here it is ptosis. Here there is no ptosis. Here it is like droopy eyelids. Ptosis more on this side than this, no? And they can have increased pigmented nevi and multiple kephiolet spots. So RAS screening this particular pathway genes, you can identify 60 to 80% of the cases with underlying gene in this particular pathway. PTPN1 accounts for majority, followed by SOS1, RAF1, RIT1, and rest of them are minor contributors. Genotype-phenotype correlation is emerging. Mutation-specific follow-up guidelines are being published. Most of them are autosomal dominant disorder. Recessive inheritance has also been described with these two genes. And now we have newer therapies, which can lead to inhibition of these particular pathway gain of function by using this rapamycin, which is used to treat severe lymphatic complications. Hypertrophic cardiomyopathy with LVOT obstructions, we can use trametinib, and MEK inhibitors can be used in NF1. So newer drugs trials, including statins have been used in this particular group of disorders. So genotype-phenotype correlation, PTPN1 mutations, more likely to have pulmonary stenosis, less likely to have septal defect, most likely to have HCM, and only exon 3 mutations are likely to have ASD. And bleeding risk is higher in cases with PTPN1 mutations. RAF1 mutation, majority of them present with hypertrophic cardiomyopathy. RIT1, almost all of them can have some sort of congenital heart disease. These children frequently manifest with lymphatic complication, especially in the post-operative period, like they can present with chylothorax, right? So that has to be kept in mind. SOS1 mutations, on third will have hypertrophic cardiomyopathy. Here the short stature frequency is less, whereas HOC2 mutations, the commonest cardiac lesions here are septal defects as well as mitral valve dysplasia. So these are few points which have been published in the recent literature about how the genotyping might help in future in terms of prognostication, monitoring, and treatment aspects. This is the child when I'd seen at 8 months old with ASD. He was operated, 8 months old, looked dysmorphic, some sort of lax skin. I never thought it might be a Noonan syndrome. Later, at the age of 6 years, he came with short stature, undescended testes, low set posteriorly rotated ears, down slant eyes, not very typical face of Noonan syndrome. He was found to have PTP and 11 gene mutation in the exon 3, which is commonly reported with the ASD, right? So that gave us a diagnosis at the later age that this child is a case of Noonan syndrome. Coming to Holt-Oram syndrome, again, it is majority of them have septal defects. In 75% are known to have congenital heart defects. In addition, they can have conduction defects as well. Life expectancy in Holt-Oram cases is limited by arrhythmias and severity of congenital heart disease, and the commonest gene is TBX5 mutations. So this is a familial case. Grandmother had ASD. She was operated. Mother had skeletal defect. Echo was normal. If you see her hand, see the hypoplastic thenar eminence and hypoplastic thumb as compared to this thumb, right? So her echo was normal, but the child hands were like this, and child had ASD and VSD. And when we did the TBX gene sequencing, it showed this particular pathogenic variant. So the penetrance of skeletal defects is 100%, whereas penetrance for CHD is 75%, indicating clinical variability. So these are the Holt-Oram simulating syndromes which need to be differentiated clinically. They can present with radial ray defects like TAR syndrome, Fanconi anemia, Vactral, Townes-Brocks, ulnar memory, Duane's radial ray, and acrorenal ocular syndrome. Coming to valvular heart lesions and aneurysms, they can be inherited and acquired, like acquired in case of rheumatic heart disease, abdominal aortic, all those are acquired form. The commonest inherited valvular lesions are bicuspid aortic valve and mitral valve prolapse. Other inherited lesions, these are the type of lesions, like it can be absent valve, prolapsing valves, stenotic valves. Don't label all valve lesions are due to rheumatic heart disease, right? We hardly see rheumatic heart disease now. So underlying causes, commonest cause could be connective tissue disorders, rasopathies, or rarely it could be LSDs. Rarely it could be other chromosomal causes. Other causes could be LSDs, alkaptonuria, and familial hypercholesterolemia. The important cause for valvular heart disease and aneurysm is Marfan syndrome, a dominant disorder which is highly variable, clinically variable, and show age-dependent penetrance, mainly involving 3 systems, that is cardiovascular, eye, and skeletal system. And the underlying gene is fibrillin 1 gene, and 25 to 30% are sporadic, majority are familial. So there is again diagnostic nosology which is used to diagnose or exclude Marfan syndrome, which is unreliable in children because of age-dependent penetrance, right? So in children, best discriminating factors are, along with heart aneurysms, dilated aortic root, ectopia lentis, aortic root dilatation more than 3 standard deviation, height more than 3.3 standard deviation above the mean can accurately classify Marfan syndrome in as many as 90% of the cases. So these are the additional clinical features, physical features: pectus deformity, thumb sign, wrist sign, skin striae, and the typical face: mylar hypoplasia, downslant eyes, deep set, They can have microretrognathia, right? And long narrow face. So this is the Ghent 2 nosology diagnostic criteria, not what we use earlier. There was Ghent 1 nosology. Practically, this is more easy to apply in the OPD, and they give more importance to the aortic root Z scores. So aortic root Z score more than 2 with ectopia lentis, we can easily diagnose it as clinically as Marfan syndrome and subject them to genetic testing. In addition, other things are there, systemic scores as well as skeletal scores, which can be used in the diagnostic criteria. So this family came to me after the marriage, to understand the risk of recurrence in the risk of transmission to the child. And he was operated for 4 surgeries, starting from 2000 to 2008. Once he was operated for aortic root replacement, the risk of having further surgeries also increases as high as 80 to 90%. This part of the aorta is involved, further next part, distal part can get involved in some of the cases. So essentially the father and the parents were, they didn't wanted to transmit this. They wanted to have a pre-implantation genetic diagnosis. So we offered them clinical testing on the proband first, which showed FBN1 mutations, which can be used for PGD or PGM, what this calls. Rarely we see autosomal recessive Marfan syndrome. Parents were just tall, echo was normal, child presenting with classical Marfan syndrome. So Marfan syndrome need to be differentiated from Marfan-related disorders in the TGF-beta signaling pathway genes, that is Lewy-Dietz, Pringens, and MAS. And there are overlapping other connective tissue disorders like Ehlers-Danlos and homocystinuria. So management is multidisciplinary, medical and surgical. Pharmacological protections to prevent aortic root dilatation, there are many ifs and buts. What we do is as soon as the child is diagnosed with Marfan syndrome or related disorder, we start with losartan, right? If there is not well control on the losartan, we add beta blockers, which is used for both drugs, seems to work in a better way in preventing aortic dilatation and related dissection and deaths. This is other rare disorder, cutis laxa syndrome with variable internal organ malformations, especially aneurysm. I'll quickly go to type 1, which is associated with giant aneurysms. So this particular gene, homozygous mutations, is reported in particular North Kerala community called as Mapilas, where they have a founder mutations. They have lethal arteriopathy, giant aneurysms will be there. Most of them die in the early childhood, and they have characteristic face as well as physical findings of cutis laxa and additional arterial tortuosity. So this is the giant aneurysms character. This is the area where it has been reported. So these are the children from our place, indicating that the similar mutations indicating endogamy, as well as this is the same gene with again giant aneurysm, homozygous fibrillin 4 gene. The other important syndromic CSDs are Goldenhar syndrome and Klippel-Feil. Again, here there are some genes reported. Most of them are sporadic with unknown genetic cause. Empiric risk of recurrence in Goldenhar syndrome is 2 to 3%, whereas in Klippel-Feil syndrome, majority of them are sporadic with negligible risk of recurrence. And of course, it has to be differentiated with other additional overlapping syndromes as well. And these are the genes. Lastly, coming to environmental exposures, maternal effects, and teratogens causing congenital heart disease. These are the groups which have been suggested to cause congenital heart disease. Teratogen exposures, rubella, thalidomide, anticonvulsants, alcohol, and other drugs. nutritional deficiencies, folic acid, vitamin A, D, etc. Intrinsic factors like maternal diabetes, obesity, phenylketonuria, viral infections, and hyperthermia. Of course, these always they will act with the background genes. So this is the recently published paper where they used these particular factors, modifiable factors, to predict whom we should subject for fetal echo. So as to increase the identification, or increase the diagnostic yield of fetal echo. Yes, that is what they used in this nomogram published in this article. They provided nomograms to identify high-risk individual to subject to fetal echo, irrespective of ultrasound findings. So the problem in these environmental factors is small sample size, quantifying is difficult. The always background genes, ethnicity will complicate these studies. So diabetes is one of the important risk factors for congenital heart disease. This is with TOF with sacral agenesis. The risk of congenital heart disease increases to 22% if the HbA1c is more than 8.5%. And the commonest cardiac lesions are conotruncal heart defects and hypertrophic cardiomyopathy. Anything, any diabetes with this particular HbA1c, yeah. Fetal valproate syndrome, now nobody uses. Earlier we used to see these cases many with characteristic face and congenital heart disease. I'll skip these. This also nobody uses now. A child born to a mother with epilepsy on phenobarbital, as you can see here, hypoplastic nails and characteristic face with TOF operated at young age. So what is this case? Blepharophimosis, smooth philtrum, thin upper lip. What is this case? Fetal alcohol. Yes. I think fetal alcohol syndrome is in India is likely unreported. There are very, I could find only one, this study from Nimans, who studied alcohol abuse among women, which was less compared to the men. And they studied 26 children exposed to maternal alcohol. Of course, they had this low birth weight, reduced head circumference, and physical scores, abnormal physical scores were high. Compared to the Western countries, in India, there are very few published cases. So this is the, how we go about when we see a child with congenital heart disease. If it is syndromic, identifiable phenotype like Down syndrome, trisomy 18, do just karyotype. If it is microdeletion, this is DeGeorge Williams, do microarray. So if it is not fitting into any, start up with chromosomes and microarray. If it is normal, then go for exome sequencing. If it is directly fitting into single gene disorders like Noonan syndrome, Alagille syndrome, something like that, go for exome sequencing. And going for clinical exome or whole exome, it depends upon your threshold for the diagnosis. If it is atypical, better to go for whole exome. If it is very typical, characteristic, this is the only gene, then go for clinical exome. If it is isolated CHD, then if it is familial, consider clinical testing. If parents are wishing, counsel them about low diagnostic yield and rarely clinically useful. And if it is just an isolated without family history, or even if it is familial, consider genetic testing if research facilities are available. This cellscape, this is a child who was operated for congenital heart disease in 2007. That time we did karyotype. Later it presented with pancytopenia at the age of 6 years, suggestive of Fanconi's anemia. This also child operated for CHD, later presented with short stature. Everybody thought it is Turner syndrome, karyotype was normal. Important clue in these cases to pick up Fanconi anemia is Microcephaly and cephaloid spots should think of Fanconi's anemia. This is another child, very complex family. Mother was short stature. First child presented with short stature and CHD. Everybody thought it is Turner syndrome. Karyotype was normal. Meantime, second child was born with esophageal atresia. Sorry, tracheoesophageal atresia. This child was born. So when we did the whole exome sequencing, we found this particular gene, EFTUD2 gene, which was coming from the mother, indicating high clinical variability, giving us the diagnosis of familial mandibulofacial dysostosis given Almeida type. So it is a multiple malformation syndrome. Let's skip that. There are many growing adults with CHD. One has to remember their needs are entirely different from children because long-term quality of life not only depends upon the type of lesion, severity of the lesions, but number of surgeries, medications, late complications, and also late manifestation of the genes as well. So to conclude, congenital heart disease can present as isolated or syndromic. So underlying syndromic causes can be single gene or chromosomal causes. Based on your clinical impression, please choose the appropriate test for each case. You know, sometimes the blood might show normal karyotype. Skin might show. You should know when to do skin chromosome analysis, when to do FISH, when to do microarray. So all those things can be done. FISH, I always do it on the parents. When a child is diagnosed with microarray or FISH, I always prefer in the parents because mosaics can be picked up by FISH easily compared to the microarray, even if it is low level, right? So accurate genetic diagnosis will help in accurate management, prognostication, risk of recurrence, extended family screening as well, along with prenatal diagnosis. So way forward in large chunk of CSDs are still unknown. Way forward is using human heart organoids, animal models, integrated multiomics, epigenetics, and also studying more of environmental exposures to understand the genetics of and environmental causes of congenital heart disease. Thank you.